Thanks for joining this afternoon for our ESID Grand Rounds webinar on the topic of malignancies in inborn errors with immunity. I'm happy to moderate this together with Michael Albert from Munich. And the first few minutes we will wait for people to join. And I would like to give you an overview of the presentation. So the first talk will be by Filippo Consoni on a puzzling case of lymphoproliferation. So it will be a patient presentation, really difficult, very instructive, with a lot of possibility to learn and to discuss. Then I will present a study that was actually conducted by a postdoc from Belgium in the Netherlands, together with the ESID registry on the epidemiology and management of malignancies in patients with IEI. Our main speaker will then be Marcin Wlodarski from St. Jude's on GATA2 deficiencies and its many phases. And then we will have a panel discussion as usually with Q&A moderated by Michael and myself together with Andisha Atabashi, Eleonora Gambineri, and yeah, please, Michael.
Yes. So you already basically, and we'll introduce every speaker before their talk. So we will have Filippo, Markus, and Marcin presenting today. And one quick reminder, if you have questions, please post them in the Q&A section, and then at the very end we will select the most interesting questions and direct them to the panel participants. So Markus and myself will be moderating, and Andisha and Eleonora will join us on the panel. Andisha Atabashi is the head of the Department of Pediatric Hematology and Oncology at St. Anna in Vienna. And Eleonora is head of the Immuno-Oncohematology unit at Meyer Children's in Florence. And with this, we start with the first presenter, Filippo. He is a pediatrician and researcher, and he is currently doing his PhD at the University of Florence in Italy. And he has joined many ESID and EBMT programs, and he will present to us a very interesting case today, a puzzling case of lymphoproliferation. Filippo.
Hello, everyone. Let me just share the screen. Okay, here we go. So I hope you can see the screen. So this is a difficult case that actually has a difficult solution. And maybe it's, comments are welcome to see if there are further solutions and further, possibilities for this patient whose care is very tough and challenging for all of us. So it all starts with this 13-year-old female who had a past clinical history of dermatitis and growth failure, and that presented to our Hemon clinic for lymphadenopathy with an abrupt onset, hepatosplenomegaly, a purplish skin rash, and hard edema in the lower limbs. We will see shortly some pictures of this rash. For the initial workup for suspected lymphoma, we performed some ophthalmology examinations, some cardiology examinations, and a CT scan, which found actually that she also had anterior uveitis, dilated cardiomyopathy, and interstitial lung disease with bronchiectasis. So of course, the first suspicion was of an inborn error of immunity, and we did a first basic immunology workup, which showed these features, so low B and NK cells, slightly elevated DNTs, high transitional B cells, high IgG. And then, of course, given the suspicion of lymphoma, we performed a biopsy of the skin and of the axillary lymph nodes and of the bone marrow, which showed atypical lymphocytes. There were T lymphocytes, monoclonal, which had nodular aggregates and aggregated in a granulomatous fashion. So the first initial diagnosis was of mycosis fungoides, evolved to Sézary syndrome given the axillary lymph node involvement. So these are the pictures of the rash, as you can see, and of the hot edema of the lower limbs. But actually, talking to the pathologist, we realized that her histopathological features were not fully consistent with mycosis fungoides. If some of you know some of the histopathological features of mycosis fungoides, you would realize that in this case, there is a loss of epidermis tropism. There are deep muscular and dermal and hypodermal infiltrates, and there is a rich intramuscular granulomatous inflammation, which is not fully consistent with this type of lymphoma, which is actually very rare in pediatrics. So, given that we're talking about IEIs, which IEI would you guess in this case? So we can launch a first poll to see what do you think about it. Okay, so I think I cannot see the solutions actually, but we can proceed saying that the first genetic examination that we actually performed was a CGH array, which showed some paternally inherited or maternally inherited duplications or deletions, which were actually interpreted as unlikely to cause the patient's phenotype. And then, thanks to Pan, Hammerstrom, and Karolinska, we proceeded with whole exome, which showed two compound heterozygous missense variants in ATM. The parents were both carriers of one mutation, so for this reason, and given the high CAD score, they were quite interesting, even though they were missense variants, and usually ATM variants are not missense, they are more frame shift or they are more deletions. But in any case, we proceeded to further investigate these interesting missense mutations in compound heterozygosity, even though they had low pathogenicity scores, as you can see in this slide. So we actually needed a functional validation of these variants, and we asked help to the lab of Jean-Pierre de Villarte at Institut Imagine, which is an expert of DNA repair disorders. We dosed actually in the clinic alpha-fetoprotein, which was actually normal. And the patient also had low naive TCD4, which could be consistent with AT, but it's also consistent with the steroid treatment that she was taking at the moment. And on the other hand, the expression of V-alpha 7.2, which is a marker of DNA repair disorders like REG SCID or Artemis SCID, this expression was actually impaired, and this could be consistent with AT. We also performed, thanks to Jean-Pierre de Villarte, a radiosensitivity assay, and as you can see, our patient had a radiosensitivity which is actually in between healthy donors, which we can see in the green dots in the slide, and regular AT patients, as you can see in the purple dots. So another question for you, is this a variant or a hypomorphic case of ataxia telangiectasia? Okay, so this was an easy question, so I think we can stop the poll here. And so to validate this question, to answer this question, we performed, thanks to Jean-Pierre de Villarté, another assay, which is a more specific assay whose details are actually explained in this very nice publication in JACI in 2019. It is an RT-PCR-based assay through which different transcripts of the T-cell receptor alpha locus are sequenced, and the length of these transcripts is comprehensively summarized in this principal component analysis graph. As you can see, different T-cell receptor alpha locus transcripts clusterized differently according to the genetic type of DNA repair defect. So there are some deficiency of some DNA repair IEIs, which clusterize in this position, and this is the case of RAG, Artemis, LIG4, and Seruna's deficiency. Other IEIs like ataxia telangiectasia and Nijmegen breakage syndrome clusterize here, while healthy controls clusterize here. So in our case, actually the patient clusterizes with healthy controls, and this actually is a quite specific assay because there is a very low degree of overlap between the three clusters. And so this actually rules out ataxia telangiectasia for our patient. But this leaves us to another question. So how do we treat this patient? So we sent samples from the lymphoma to Pan Hammarström at Karolinska in Sweden to see if there are some somatic mutations on this lymphoma that are actually targetable by target treatment. Unfortunately, there are no currently approved treatment for the somatic mutations that we found in this patient. We found especially mutations in pathways connected to epigenetic remodeling. And generally speaking, the burden of somatic mutations was not as high as we see in other AT lymphomas. So this was actually consistent with the non-diagnosis of ataxia telangiectasia. Coming back to pathology, we talked back to our pathologist in Padova in Italy, which actually notified us that the patient's lymphoma had a partial PD-1 and PD-L1 expression, which could be targeted by checkpoint inhibitors. So regarding treatment, we first treated her at the beginning of the diagnostic journey with steroids, with a good improvement. Then we passed on to methotrexate maintenance, which achieved a good stability. But when we stopped methotrexate in July 24, she had shortly a skin and muscular relapse. So we had to retreat her with steroids, and in this case, we added vinblastine. We didn't add other chemo because we had the doubt of ataxia telangiectasia, so we could not push strong on this part. So in a nutshell, we are in front of a low-grade T-cell lymphoma, which is not a variant AT as we formerly thought, which is a probable IEI given the immunologic background, the syndromic feature, the multisystemic involvement, but a diagnosis is still lacking. So how do we treat this patient? Should we add a checkpoint inhibitor or should we transplant this patient? So these are questions that still do not have an answer, but I thank everybody for your attention, and I thank all these fantastic people that has helped us in solving or trying to solve this case.
Thank you very much, Filippo. Very interesting and challenging presentation. Again, the reminder to please post your questions also to Filippo in the Q&A section at the bottom of your screen. So next we will have Markus Seidel to present. Markus is currently the ESID Registry Working Party Chairman, to which he was elected in 2022. And he's a professor of translational pediatric hematology and immunology at the Medical University of Graz in Österreich. And he will present a very interesting study, which he will be presenting also on behalf of Delphine Bogart, who is, for personal reason, is not able to present herself today, but Markus will do so instead. Thank you, Markus.
Yes, thank you, Michael. As said, this is a collaborative effort, and also Andisha helped designing the CRF for the survey. Christina's helping in the data analysis. Joris van Montfrans, Jonathan Gartmann, and Stefan Rusch and Gerhard Kindle from Freiburg were involved, and everybody from the ESID registry who entered data. So everybody will be listed as co-author on the manuscript that we are preparing. I have two disclosures to make. And I would like to start with tumor predisposition in general. As you know, there are primary risks of activating mutation in oncogenes or loss of function or haploinsufficiency of tumor suppressor genes. And the examples would be DNA repair defects that make us sensitive or even more sensitive to ionizing radiation, for example, or other toxins, and may cause impaired maturation or differentiation, or cell cycle checkpoints or apoptosis problems and so on in cells. And then there are indirect secondary risks that can concern everybody with or without immune deficiency, or with or without an inherited tumor predisposition, which is pharmacological, environmental cancerogens, chronic inflammation, for example, which leads to a permanent activation of cell turnover, impaired immune surveillance in situations where our immune system is suppressed, even physiologically, for example, in age, and infections, for example, of cancerogenic viruses or aflatoxins. And all this happens in inborn errors of immunity and is even more pronounced there. So what is the tumor predisposition in inborn errors of immunity? There are cell extrinsic causes, like I said, oncogenic transformation as a consequence of chronic inflammation and infection due to transforming viruses, for example, which lead to a stochastic risk of a transformation initiating event, and cell intrinsic causes in patients with inborn errors of immunity. Very often, the very same defect that leads to immature or blocked maturation of lymphocytes, for example, also causes the tumor predisposition, the same mechanism in the same cell. So it's in parallel. And this is also a good example would be the DNA repair disorders. So this is an inborn transformation predisposing condition, and everything works together. Plus the lack of immune surveillance in immune deficiencies leads to a progression associated event. There were big studies and like pioneer studies, you could say, although the context has been described already by Paul Ehrlich, I think more than 100 years ago. But this study from the Netherlands with about 70 malignancies in 745 patients showed an early peak in patients with immune deficiency as compared to the normal population with malignancies. And there a larger study in the US IDNet came to a similar result with 171 malignancies in about 3,658 patients, with an earlier peak in men and women with inborn errors of immunity. Most of these cancers were lymphoid, like hematological malignancies. Together with a former diploma student, Oliver Kindler, I performed this kind of meta review. It's not really a meta review, but it's a really educational subject which we called the iceberg map, where you would see the relative size of the iceberg reflects the relative frequency of these malignancies in childhood. And the tip of the iceberg was the known germline cause, germline mutations in these entities with a very high patient number. And when we looked at which mutations occurred there, many of them, like in bright blue, were TP53, of course, but many others were due to mutations in genes that we also know from inborn errors of immunity like ATM, mismatch repair defects, or inborn errors of immunity not further specified, XLP, Wiskott-Ulrich, and so on. And that the distance of the icebergs was calculated by this map and shows that most of the inborn error of immunity genes kind of circle around lymphoma. And we will see in a minute what this leads to in the clinical real-world situation. But let me mention this review before that I wrote together with Fabian Haug. I drew a kind of mind map. At the time, the term PID was still was kind of changing to inborn errors of immunity. Now we're talking about including PID again for primary immune disorders, because it's not all immune deficiency, as you know. So, and one of the intrinsic causes would be like a maturation defect in myeloid or stem cells. And we will hear more about this in Marcin's talk very soon. Then there would be defects in lymphocyte development and differentiation, and apoptosis defects, for example, in combined immune deficiencies or ALPS that would lead to lymphoma. And it's really intriguing because many inborn errors of immunity predispose to lymphoma and leukemia, not many to AML, for example. But there is a different pattern, and this is really reflected in the real world. Like, so point 3 would be lymphocyte co-signaling or cytoskeleton, cytotoxicity, and metabolism defects. Then there would be the big group, the mechanistically big group, but not in absolute numbers, big group of patients with problems in chromosome stability, telomere maintenance, and DNA repair. Then, and then we start with extrinsic causes. So like as I said before, transforming viral infections, EBV, sometimes other viruses like papilloma virus, even others can cause carcinoma, for example, sometimes sarcoma. Then the chronic inflammation with the increased cell turnover. This could actually happen in all different categories of inborn errors of immunity, and of course the impaired immune surveillance. So it's, as I said, it's really intriguing that different kinds of malignancy occur in different kinds of inborn errors of immunity. And from this, you could deduct that stem cell transplantation might be, might even increase the future risk of malignancy because it adds cancerogenic toxicity at least as long as we need busulfan or other chemo for conditioning treatment, whereas it probably reduces the future risk of malignancy in inborn errors of immunity that with malignancies, especially in the lympho and hematopoietic system. So in this big ESID study, we have data on almost 20,000 patients on their status if they ever had a malignancy, and we had 1,783 malignancies in this cohort, 484 of which had the malignancy as a presenting symptom, and this paper is currently under review. We have 1,212 patients with a specified inborn error of immunity and malignancy, and we know from 889 of them which malignancy it was. And then we made a survey on the management and on further details of this patient, of these malignancies and patients. And this was, the survey was filled out for 393 patients. And those are really interesting data, I think. So here you see that more than 20% of the malignancies are B non-Hodgkin lymphomas. It's by far the most frequent single entity of malignancies in inborn errors of immunity, and followed by breast cancer and other cancers, together more than 30%. But we have to remember that the age at diagnosis was not specified in this survey. So it's probably also including a lot of patients at older age with also intestinal carcinoma and so on. And then there is Hodgkin's disease, NHL and TALL, Burkitt's lymphoma, melanoma, and all of them occur more frequently than in the general population. So if you look at this in categories of immune disorders, you see that the Bayes theorem applies, meaning that because the primary antibody deficiencies are so much more frequent than syndromic or combined immune disorders, for example, we will, of course, have more patients with malignancies from this category, although themselves they are not predisposing with a higher frequency in one of the patients. But if you have an immunology clinic, you would probably see most malignancies in patients in the category where you have the highest patient number. Yeah, so this is basically it. In the outer ring, you see that Burkitt's lymphoma, Hodgkin's disease, and so on is occurring here. Of the syndromic immune errors of immunity, their NBS1 is leading, followed by ataxia, telangiectasia, hyper IgE syndrome, Wiskott-Aldrich, and so on. As soon as we publish this, this will be an interactive slide where you can see every single entry if you rush over it with your mouse, but also XLP, ALPS, or unclassified IEI are mentioned here, of course. If you look at it the other way around, oh no, sorry, it's still the same way around. We would have a third of patients with CVID and then other unclassified antibody deficiencies, combined immune deficiency, tumoma, Nijmegen breakage, ataxia, and so on. So this is really interesting data. It's unpublished. Please do not post this because we still want to submit the manuscript, of course, with unpublished data. So this is really educational, like a presentation at a conference, and it's about to be submitted very soon. If you look at it the other way around, which malignancies are associated with which inborn error of immunity, you can see that CVID or other primary antibody deficiencies lead in almost all cancer categories, followed by Nijmegen breakage syndrome, combined immune deficiency, ATM, XLP1, and APDS. And it's only like in TALL and that NBS1 is leading. And for most of the others, it's CVID, probably because it's also the older patients in this group. Now coming to the survey that was conducted by Delphine, we had survey data from 393 patients with 436 malignancies. The distribution of IUI's categories is the same. Here is the cohort characteristic of the sex distribution, the overall outcome, and then total number of primary or secondary or third cancers, and the age at first malignancy. We see that it was mostly leukemias and lymphomas, as mentioned before. Here we also have the stage of the disease at presentation. And we asked about the oncological treatment. It was influenced by the diagnosis of an inborn error of immunity in about a quarter of the patients, and there were multidisciplinary boards, not in all, but in the majority of situations. And I highlighted here that the inborn error of immunity was an argument pro stem cell transplantation in about a sixth of these patients. The outcome, so many people, in many patients, it was thought that the IEI adversely affected the oncological outcome, but in the majority, they said no. And we also asked about the current state of the malignancy and the place of follow-up, which is mostly in the oncology clinic, or which I think is very good in a combination of the oncological and an immunological clinic, although sometimes it's the same person. So last but not least, I have a I would like to show you here the Austrian recommendation to monitor patients. Please excuse that this slide is in German, but we developed a monitoring recommendation for Nijmegen breakage syndrome and ataxia telangiectasia with the frequency per year of different investigations that we would recommend. And you would see here that what we usually don't do in pediatric oncology is that we would look at some kind of tumor markers like the paraprotein screening and light chains, for example, expecting clonality as a predecessor. And I learned this actually from the Polish NBS cohort, and I think we should discuss on this to develop an ESID guideline. And we have similar sheets for NF1, Li-Fraumeni syndrome, Fanconi, and so on. And with this, I would like to summarize and say that inborn errors of immunity predispose to malignancy with varying probability. The base statistics apply. So in your outpatient clinic, most of malignancies in IEI will occur in primary antibody disorders, then in syndromic, combined immune regulatory disorders, and other. Extrinsic and population factors have to be considered, like chronic inflammation, infection, the IgA deficiency in the gut causing dysbiosis, Helicobacter, and so on, and age. Cancer subtypes reflect the cause of the malignant transformation, of course. So we saw in real world what's happening in the pathway of the IEI. And the management and outcome is strongly affected by the IEI. Multidisciplinary team decisions are made in over 70% of the patients, and in 24% treatment modifications were made. In 15%, it had an influence on the transplant indication, and in 31%, it was estimated that the outcome was adversely affected. So I think it's really important that you are aware of the risks, that you perform personalized screening, monitoring, and treatment. And for this, I would really say, talk to each other, hold board meetings and so on, and talk to your pathologist what to expect when you send biopsy samples and so on. And with this, I would like to thank you and people in my team who contributed to this data collection. Thank you.
Thank you, Markus, for this excellent presentation. Very interesting data. I will let you introduce our next speaker then.
Yeah, so thank you, Marcin, for joining here today. Marcin Wlodarski is a physician scientist who specialized in bone marrow failures and pediatric myelodysplastic syndromes. He trained in Berlin, in Stockholm, in Cleveland. He worked in Berlin and in Freiburg for a long time at the EVOC MDS Studies Center. And since 2018, he is an assistant faculty member at St. Jude's in Memphis in the Department of Hematology. And since 2022, he's a director of the St. Jude Bone Marrow Failure MDS program. So I'm really looking forward to Marcin's talk about GATA2. Yeah.
Thank you very much. Let me see. Are you able to see my screen?
Yes, but
okay,
not in presentation mode yet.
How about now?
Yes, now it's perfect.
Okay, perfect. Thank you. So I'm really excited and honored to be here. You know, as a European, I love to be invited to European meetings, but I'm also a little bit terrified and nervous because I have to present to so many immunologists. You know, so I'm hematologist by profession. So I will start with this. So in 2013, when I was a resident back in Freiburg, University of Freiburg, a nurse from outpatient clinic writes a note to me, callback note, please call the patient X6 with GATA2, right? And then I thought, okay, as a resident, you have to give a brief pep talk to a nurse. What is GATA2 deficiency? So first of all, we know GATA2 is a chief hematopoietic transcription factor. And this transcription factor recognizes this 4-nucleotide sequence, GATA, and it binds to it. Number 2 for GATA2 is arbitrary. There are other GATA2 transcription factors that are specific to other tissues. So we know GATA1 to 3 is hematopoietic group, GATA3 to 5 is cardiac group. And now I would like to give a brief overview of landmark discoveries in GATA2 deficiency. And I apologize upfront if I know many of you have also published or contributed to GATA2 deficiency as research, and I'm not able to show all the discoveries. I want to focus for the purpose of my talk on only some discoveries that show the landmark phenotypes in GATA2. So the syndrome by itself has been first described by in the French literature by Dr. Emberger in 1979. So he reported families with deafness, lymphedema, cytopenia, and also AML. Then in 2009, another French group has published syndromic patients with MDS and monosomy 7. And this patient had a large germline microdeletion on chromosome 3q. You see here on the right, many genes, GATA2 sits right in the middle. And the authors back then speculated that this might be contributory. However, there were too many genes to be conclusive and to really call it GATA2. Then exactly 14 years ago, there was an avalanche of papers from different groups, and this was made possible through whole exome sequencing technology. And these groups found GATA2 germline mutations in variable cohort of patients. So one group from London studied lymphedema and identified this in these patients with lymphedema, previously called Emberger syndrome. Then the group of Hamish Scott from Australia, who collected patients with familial MDS. The NIH immunodeficiency group, who had cases of new immunodeficiency syndrome with monocytopenia and mycobacterial infections. They called it monomag. And finally, another group with interest in immunology and dendritic cells from the UK, who found cases, what they termed it DCML, so dendritic cell monocytopenia lymphoid cell deficiency. And in 2013, the French Neutropenia Registry has published a case series of GATA2 deficient patients who initially presented with neutropenia phenotype that then evolved to MDS. And finally, in 2016, the European Working Group on Pediatric MDS showed that GATA2 mutations account for 15% of advanced pediatric MDS, and the prevalence is particularly high in patients with monosomy 7. So as shown here on the right bottom, over 70 patients who are adolescents with monosomy 7 have GATA2 deficiency. So I think this is important for pattern recognition. If you have a patient who is an adolescent and has monosomy 7 MDS, the probability this patient has GATA2 deficiency is very high. It's probably 2/3. And when preparing for this talk, I also revised the literature and came across this interesting educational article in a dermatology journal. So essentially, it was on skin manifestation of GATA2 deficiency. And I was quite positively surprised by this statement of the dermatologist that dermatologists need to recognize patients with GATA2 deficiency because it can be successfully treated with transplant. And I think he should also add, if you're in Europe, you should reach out to immunologists, for example, the ESID group, because they would be able to advise you when they see certain skin findings, obviously which syndrome this could be. So I think here the doctor is referring to severe verrucosis vulgaris, which I will show you later. So now, what phenotypes are recurrent in GATA2 patients? First, I would like to summarize the immunological abnormalities. Loss of B and NK cell progenitors was described in GATA2 bone marrows by Collins group from the UK. They found that transitional B cells are absent and there is a slight expansion of CD38 negative, CD28 negative cell population. This might be associated with autoimmunity we see in these patients. Also, the most juvenile NK cells were lost. Esther May-Strikova group in 2016 has shown that B cell loss is the most consistent phenotype of GATA2 deficiency, since many patients can have still normal NK cells, but the most consistent, even in patients who have normal CBC, they can have low B cells. And an interesting general observation is that despite B cell loss, the immunoglobulin substitution is rarely required. So I have actually never, my patients never needed immunoglobulin substitution. Now, as for the monocytes, although initial studies have reported monocytopenia as one of the common phenotypes, we now know that this is not specific features because many patients can have normal. Some patients can even have increased monocyte counts. So it can be either related to the MDS transformation, of course, the malignant monocytes, but we have seen it also in a few infants where it occurred as non-malignant infant monocytosis, kind of like a myeloproliferative phenotype that is non-malignant polyclonal, kind of like a TAM disease that can be transient and can then disappear. So we have seen so far 3 or 4 infants that have this phenotype, which is quite interesting. Other features include loss of dendritic cells and CD4 cells. The CD4 to 8 ratio can be reverted, like in patients with AIDS. Autoimmunity is also seen in at least 11% of patients. It can be associated with immune cell cytopenias, skin, joint problems, and it can also mimic lupus or sarcoidosis. So actually immune cell cytopenia, so we have patients who initially presented with autoimmune hemolytic anemia or ITP-like picture. And as you know, infections are among the most common phenotypes in GATA2. So as shown in the NIH study on the bottom left, by age 40 years, over 70% of patients will have experienced severe viral infections. In the French registry study on the right, 50% of patients were shown to suffer from HPV infections by age 40. This can be generalized infections like on the hands of this patient here, and it can also lead to HPV-related cancers, so cervical CIN and HPV-related CIN in women, but also other HPV-related cancers. And there is a range of other viruses associated with GATA2 deficiency, for example, EPV or HSV or JC virus. Mycobacterial infections are common, estimated up to 42% by age 40. Most common is Mycobacterium kansai. And similarly, bacterial infections, including Clostridium difficile or strep, are encountered also in many patients. Fungal infections can manifest in at least half of the cases. Now, my favorite topic, obviously, is the hematologic disease spectrum. And here I try to put together the main hallmarks from least malignant to the most malignant. So on the left is the least malignant side of the spectrum, and patients have marrow failure-like picture with cellular deficiency. So you could call it marrow insufficiency. It's not a true bone marrow failure, but it's more like stem cell deficiency. One interesting thing is that hemoglobin and platelets are often initially normal in these patients, and they initially present rather with neutropenia, and over time they can develop pancytopenia. Initially, the marrow shows no dysplasia. Then we encountered the pre-malignant phenotypes. These patients have hypo or normal cellular marrow with dysplasia. This would be, in children, we would call it refractory cytopenia of childhood. In adults, RCMD. Certain somatic alterations are also present in this group, like trisomy 8 or A601 and STAC2 mutations. And finally, the malignancy phenotype, characterized by the presence of high-risk lesions, such as monosomy 7 or ZBP1, or the RAS pathway mutations. This is also the patients who have advanced MDS, MDS with excess blast or AML, CMML, MPN, and myelofibrosis picture in adults. And also 3 cases of ALL were reported. Interestingly, 2 of them had monosomy 7, so which is atypical for ALL. The non-hematological features are very diverse. However, we find recurrent patterns. So here we reviewed the phenotypes of 500 cases from literature. On the top, you see autism spectrum disorder and ADHD was described in 12% of patients. So this is, I think, even though autism and ADHD is quite common in population, I think we see a increased penetrance in GATA2 deficiency. So definitely, if you have a patient with cytopenia and ADHD, you would have to think about it as a potential disease. Then deafness, as I said, 9%. One specific feature of GATA2, very rare, is ptosis. It can be mistaken for Horner syndrome. Then, of course, the immunological phenotype of pulmonary alveolar proteinosis, which we do not encounter in children. It is found in 18% of adults with GATA2. About 20% of cases present with urogenital tract abnormalities. Another 25% of patients have lymphatic and vascular complications, including thrombosis. And also, most importantly, immunodeficiency develops in almost all the patients over time. Now I'd like to present to you some unpublished data from our group. So Levi Kottmeyer is a postdoc in my group who compiled 1,000 cases with GATA2 mutations. You can access the database via this link, and I will show it to you in a moment. So 94% of the patients are symptomatic, from mild to severe. So sometimes very mild could be normal CBC, yet low B cells, and when you look deeper, or very mild bone marrow changes or very mild neutropenia. To severe, it would be obviously life-threatening immunodeficiency or MDS AML. The median age at diagnosis in this cohort is 17 years, so from 0 to 80. MDS in 61% of patients, infectious immunodeficiency in 70%, non-mycobacterial infections, 44 of this cohort, and mycobacterial in 16. Then we also see non-hematologic immune phenotypes in 66%, and that includes lymphedema, including hydrocele, 16%, and deafness in 7%. Now let me briefly, I would like to show the functionality of this database. So when you go, this is a beta version still, so here we don't have all the data. But when you go on seju.org/GATA2, you find all the variants reported and also the publications where it was reported with the PMID numbers and the links. Then you can search for a variant. So the idea here is that we also help in variant interpretation. Then when you click on the GATA2 visualization link, you will see the map of mutations. Then you can click on certain mutations. You can see some hotspot mutations like the arginine 362. You can click on it, and what you have is a pop-up of these variants with additional phenotypes. So we are continuing to build this and expand it. For now, this is just the beta version, but we would be grateful if you have suggestions and comments, or if you want to contribute patients. Okay, let me continue. Sorry, I'm gonna share my screen again. Okay, so here is some preliminary analysis from these 1,000 cases. On the top, you see the enrichment of variants across the gene. In orange are the loss of function variants, which are found throughout the whole protein. So about 60% of patients have these loss of function variants. Then in yellow, you see the missense variants, which are mostly in zinc finger 2. They decrease or alter the binding of GATA2 to target genes. By the way, we never found a biallelic GATA2, so that would be probably lethal. So most of, all of them are only monoallelic, and we believe they are loss of function through various mechanisms. So, and the third mechanism and the third type of mutation we observe is intron 4 regulatory region mutation, which decreases GATA2 expression. So this is a hypomorph mutation. A small subset of these patients can have intron 4, and I will show you actually how this is associated with milder phenotypes in a few slides later. Now, we also asked the question, how common are the variants we find in our patients in the large population database called NOMAD. This NOMAD database contains hundreds of thousands of healthy genomes. And on the x-axis, you see the frequency of patient variants and the NOMAD healthy population. So on the left is basically non-existent in healthy people. On the right is 1%, so it increases from left to right. So strikingly, we find that the vast majority of patients' mutations are absent in the general population. And of course, this aligns with a high penetrance disease, a disease that has high penetrance for malignancy and also immunodeficiency, which would kind of prevent these cases to be studied by NOMAD as a healthy genome, right? So majority of these variants are novel, and the variants that are found in population from, again, here, those are the single cases here in gray color, most of them. Most of them are variants of uncertain significance where we are not 100% sure they are actually causative. So for example, those are missense variants outside of zinc finger 2, and they are quite ambiguous. So overall, we believe that the majority, or if you have a novel variant or novel variant, the most likely, it's very likely that this variant will be pathogenic. We did a sub-analysis from a cohort of 200 children with MDS. Let me show this. I would like to direct your attention to the top left diagram. So what we did here, we looked at roughly 200 children with MDS and also their family members. Of the symptomatic cases, 120 had MDS, which we called advanced MDS. So essentially MDS with blasts or monosomy 7, because this is a high-risk lesion. Then 67 had early stage MDS. Those would be low blast MDS in children, and also in adults are CMD in absence of monosomy 7. And 18 had other cytopenia not consistent with MDS diagnosis. Then on the bottom left, you see the proportion of children who develop MDS over time. And it is important for our surveillance strategies, because what you see here is that we rarely see children below 6 years of age who develop MDS, but the risk is increasing during school age and really takes off in adolescence. So obviously, if you have a child with 2 years, that is 2 years of age or 3 years of age, that has been identified through family screening, we would not recommend doing bone marrows in this child because the risk is really exceedingly low. So it starts during school. So maybe if the child during school age, around around 6 to 10 years of age, has abnormal CBC blood counts, that would trigger bone marrow analysis. And then at one point we would have to do yearly bone marrow analysis to make sure we catch the MDS evolution early. Now on the top right, you see here we looked at the difference in variant types between the symptomatic group and the asymptomatic group. And what you see here is that the intron 4 regulatory mutations, which are in gray, they are enriched in the asymptomatic group. On the other hand, the symptomatic group has more null mutations. So, the loss of function, whole gene deletions, frameshift truncating mutations. So all the mutations that cause the protein to degrade or be absent. Missense proportion is similar across both groups. But we believe that the null mutations have higher penetrance. Now, on the bottom, you also see along similar lines, majority of de novo variants are null. And de novo means they are found in the patient only and not in the family members or not in parents. We believe they are high penetrance and they manifest early in life. In the familial cases, we had more missense variants. Again, this aligns with a slightly milder phenotype. However, the missense variants can also present with MDS. So I'm not saying that if you have a missense variant, you have less risk for developing MDS. It's absolutely not true. So you definitely can develop MDS and severe immunodeficiency. And now we also looked for surveillance purposes. It is important for us to know the somatic mutation spectrum in GATA2. So we looked at the somatic mutations that were found in this pediatric cohort, and for comparison, in the in roughly 40 adults, where 10 cases had somatic mutations. In the pediatric cohort, 78 cases had somatic mutations. So the box on the left, in this box, you see 3 karyotype groups that are common in these patients. Monosomy 7, -7 on the top, trisomy 8 in the middle, and the normal karyotype on the bottom. Now, when you ask how many of them have somatic mutations, so we see that 77% of monosomy 7 cases have somatic mutations. So there is definitely an enrichment here. Half of trisomy 8 cases, and only 1/3 of normal karyotypes. Now, from the top to bottom, you see the most common genes found, mutated genes that were somatically mutated in the pediatric cohort. So ZBP1 is the most common because monosomy 7 is very common in children. This is followed by A601, then STAC2, RANKS1, EZH2, and the RAS pathway mutations. We also see in some cases second site GATA2 mutations on the other allele, and these are mutations that are actually providing more malignancy to the stem cells and making them more malignant. So this is more malignant phenotype. But nonetheless, what you see in children is there is an association between these mutations and monosomy 7 karyotype. So the vast majority of mutated cases have monosomy 7. In the adults, it is more heterogeneous. So you have A601, STAC2, EZH2, and obviously the background karyotypes are more heterogeneous. Now, we also looked at the prevalence of somatic changes across age groups, and this is shown on the right. So what you see is we group these patients into age group 0 to 6, 6 to 12, 12 to 19, and over 19 years of age. And we asked what is the proportion of the different somatic alterations across these groups. So what's interesting is that the monosomy 7 is has quite high prevalence in children. Along monosomy 7, ZBP1, because it tracks together, so it occurs together in patients. So you see that in children, in the youngest, in the school age and adolescents, this is quite high. and then it drops in adults above 19. The prevalence of monosomy 7 and ZBP1 goes down. And on the other hand, AS601 stays the same across the whole age group, and trisomy 8 and STAC2 is increasing, so from left to right. One note to say about STAC2 mutations, they were also previously found to be enriched in stable patients by the Pasquet group from France. It was published in 2 years ago in Hematologica. And the hypothesis here is that STAC2 actually provides some advantage to the stem cells. It's not a malignant clone per se, but it's some type of somatic clonal rescue. And in fact, we see now more and more patients who are, for example, parents of our patients who have immunodeficiency phenotype that did not develop MDS as children, and they have a STAC2 somatic mutation. So I think this is an interesting area to be studied in the future, and to understand how these STAC2 mutations actually help the stem cells survive or potentially not further decline. Okay, so now finally, on the last 2 slides, I would like to briefly touch upon the therapies and outcome. So one fact is that we cannot miss is that almost all patients develop severe disease and die if not transplanted. In the NIH study, all patients who were asymptomatic develop disease over time, and this is on the top left. In the middle, you see that patients without MDS by age 20 who were followed and all developed MDS by age 50 to 8 years of age. So this is basically the prevalence of MDS over time. And on the bottom is that transplant-free survival, which was worse in the older patients. However, I want to show you one recently published case of a 61-year-old asymptomatic man who had a reversion of the germline GATA2 mutation in blood and was disease-free, although his children developed severe disease. And what you see here is that the mutation which he has is actually reverted in the stem cell to a wild-type protein version. So basically the mutated amino acid reverts back to the wild type, and this is found in a subset of stem cells in hematopoiesis. However, why this is interesting, so far it has been described only one time in the 1,000 cases that we know. So this does not justify to wait and hope that such reversion occurs. So I think it's interesting to see, but I think it's not a common feature in GATA2 deficiency. Unlike in other syndromes, for example, immunodeficiency with reversion in lymphocytes or Fanconi anemia with somatic reversion. And we definitely know that the survival from transplant is excellent the younger the patients are. This was shown here on the left by the French cohort data showing then the overall survival of nearly 90% for patients below 18 years of age. And also the disease stage might play a role. This was shown here on the right by Rachel Bortnick. Patients with normal karyotype and refractory cytopenia of childhood, this is the green dashed line, have a disease-free survival of 90%, so after transplant. So this is an excellent data showing that if you transplant patients early at an early disease stage, they have very good survival, very good overall survival over time. And this final slide summarizes the natural history of disease. So initially, we believe that patients have normal cellularity, CBC is normal, no infections over the first few years. Again, we have very few single cases that presented to us with myeloproliferative-like picture with non-malignant myeloproliferation that improved over time. But those are very few cases. So far, we believe when we look at our family members where children were identified through family screening, we find that these children actually are either not affected at all or might have some mild B-cell lymphopenia. That's it. Then over time, during school age, there is a high risk of MDS evolution. The karyotypes associated are monosomy 7, also derivative 1,7, which causes loss of chromosome 7, trisomy 8, and normal karyotypes, somatic mutations associated AS601, ZBP1, STAC2. Then patients who do not develop MDS, they continue to develop a stem cell loss. And these are the patients whom we see or you see who present to you with immunodeficiencies. So cellular deficiencies, bone marrow failure like with low B cells and K cells, dendritic cells, low monocytes, macrophages. And then these patients over time, even though they might be stable for many years, they might still develop a myeloid malignancy as an adult. So for example, adult onset MDS, AML, MDS, AML, CMML, and MPN. Now, instead of a summary slide, I have developed a multiple choice question, only one I would like to present it to you. Do you still have time to show this? Otherwise, I will stop.
No, please show it.
All right.
Please do.
Okay. Okay, so I think it's important to know that obviously as an immunologist or as a hematologist, I need help from immunologists to advise me when is the best time to transplant the patient based on overall immunology assessment, but also the overall picture. And now this is a question that kind of shows the problems in deciding which patients to transplant. So a 42-year-old father with GATA2 deficiency developed pulmonary alveolar proteinosis and recurrent mycobacterial infections before receiving a transplant. His 10-year-old daughter was also diagnosed with GATA2 deficiency, but is currently asymptomatic with normal blood counts. Which of the following is the most appropriate management plan for the daughter? So A, proceed immediately with transplant using 18-year-old brother who is HLA match, has normal blood counts, but who has declined GATA2 mutation testing. B, perform HLA typing on family members to identify potential donors, conduct baseline bone marrow evaluation, and consider preemptive transplant before the onset of MDS or acute leukemia. C, monitor the patient with blood counts every 6 months and yearly immune function testing and bone marrow exam. Proceed to transplant only if she develops significant cytopenia, MDS, or severe infections. D, recommend prophylactic antimicrobial therapy and annual pulmonary function testing, deferring transplant. So not doing the transplant for now. No need for surveillance as her risk for MDS or immunodeficiency is very low and negligible. Okay, so she's 10 years old. We know that this is not true. The last one is not true because her risk is actually quite high when she is in school age and going into adolescence. Then the second last one, D, recommend prophylactic antimicrobial therapy and annual pulmonary function test deferring transplant. This is not needed because she doesn't have immunodeficiency. Of course, when we dig deeper, look at her B cells and K cells and so on, she might have low B cells, but her neutrophil counts are normal, so she doesn't need antimicrobial therapy. Then number C is, actually, let's go from the top. Proceed immediately with transplant using 18-year-old bladder, has normal CBC but declined GATA2. So obviously, the brother declined GATA2 mutation testing. And in fact, there were a few cases reported where individuals was transplanted from their siblings who had normal CBC. Years later, they developed MDS AML, which was donor-derived, and we found retrospectively that these were donors with GATA2 deficiency. Even though they had normal blood counts, when you look at their bone marrow, they might have some slight dysplasia, or they might have B cell deficiency. So I think it's important to do definitely a genetic testing of potential donors in the family if you do family matching. Then B, perform HLA typing on family members to identify donors, conduct baseline bone marrow, consider preemptive transplant. So this is an interesting question here. I think for now, we are not there yet to do preemptive transplants in GATA2 deficiency, because obviously you have risk from toxicity, you have infertility, so it would have to be decided with the family. If this was a matched sibling donor, HLA matched sibling donor who was non-GATA2 carrier, I would potentially consider doing the transplant. But if it's unrelated donor, we always have the risk with GVHD and other risks. So for now, what we can offer is to monitor the patient with blood counts, do the annual bone marrow exam, and proceed to transplant if you see that she develops immunodeficiency, MDS, or cytopenias. So with that, I would like to thank you for your attention, and I'd like to acknowledge my group in Freiburg, Lily Kottmeyer especially, who developed the database, our internal and external collaborators. I would like to mention European Working Group on MDS, which really contributed greatly to this cohort. And I would like to also feature the 3D GATA2 consortium in Europe led by Marlene Pasquet. Thank you very much.
Yeah, thank you very much, Marcin, for this fantastic overview and detailed molecular and clinical pathological development in patients with GATA2. So there were a lot of questions already in the chat, which I tried to answer besides. And I saw that also in the Q&A, there were questions already replied to by some of the participants.
Markus, can I just
Please.
try to share my experience linking up to the last slide of Marcin? Actually, we diagnosed the GATA2 13 years ago when the gene was just discovered. In a young patient, he was 7 years old, and he was referred because of low NK and low monocytes, but no other symptoms. So at the end, we decided to follow him up. Every 6 months, we will perform a bone marrow aspiration and look for the first signs of myelodysplasia. We typed the family, and he had, fortunately, an HLA identical brother who didn't have the mutation in GATA2. And at the end, at the first sign of monosomy 7, we transplanted him. And he's actually, doing well. He lives a normal life. He's adult now, and he didn't have many problems related to the transplant. So I think it's a very well taken question that still lots of clinicians somehow they have, it's a little bit troublesome to decide what to do if proceed with transplant when, because it's a kind of like also a very difficult disease if you think about all the complication, infectious complication and so on. So I think, there is still lots to do given the high, incidence of this disease in the myelodysplasia pediatric population. So I think guidelines or shared experience will be of help for sure.
Absolutely. I think it's important to tell the patient that the penetrance is very high. Sooner or later, almost every patient will develop the disease and die from it, right? However, we don't know when. So some might develop at age 10 or 13, like your patient. Some might develop it when they are 30, right? And until then, let's say until 30, they might have had 3 children, right? If they were transplanted, maybe then the fertility would be affected. We don't know that. So I think it's like difficult discussion. But I think now we have to work on better regimens for transplant. So, for example, at the NIH, there is this new trial that uses anti-c-Kit antibody for conditioning instead of busulfan. And I think that might be a good new approach with less toxic conditioning, where you could transplant the patients earlier, right? And of course, managing the GVHD is an important part, right?
Yeah.
I may maybe continue with another question from Marcin. It's in the Q&A. In patients with GATA2, what is the probability of having malignant neoplasms such as leukemia or lymphoma or malignant neoplasms due to HPV infection if the patient has myelodysplastic syndrome? And with the second question, what protection does the HPV vaccine provide in patients with GATA2 deficiency? I think you mostly answered the first question in your talk, but the second one is really interesting.
Right. I think for the second one, I would defer to our expert immunologist. But the first one, I think we know that the HPV-related HPV-related phenotypes, they improve after transplant. We have seen patients who had lots of HPV, varicoses and CIN also in women that improved after transplant and basically disappeared. The risk of HPV-related cancers in women is quite high over time. So I think if they are not transplanted, we see quite many women in their 40s who develop HPV-related cervical cancers. I have not heard of many. I mean, there are some patients also with anorectal cancers, HPV-related, but maybe not as common. I mean, there's those single case reports, and obviously these patients die from other issues by then. But I think that the most important thing is when you transplant them, that risk is gone. In terms of lymphoma and leukemia, so this is not really that high. There are only so far 3 or 4 cases in literature of lymphatic leukemia, ALL, and 2 of them had monosomy 7. So it's not clear if this was just, an incidental ALL that happened, because ALL is common in children. So maybe that happened on top of GATA2, or whether GATA2 predisposed to it. I would not kind of, I would not want to tell you that this is related with ALL. I think I'm not sure. Lymphatic leukemias are probably not risk. GATA2 is not a risk for lymphatic leukemias. And finally, what we see in some women is breast cancer. So it's quite common, but I cannot give you the exact percentage. But the question here is we would have to look at population frequencies also and do a good statistical analysis to make sure that GATA2 really there is a predilection for breast cancer. But this is what we heard when we look at family histories, that breast cancer is also prevalent in these families. In terms of the HPV vaccine, I would defer to you guys because, you know, of course we recommend that, but I'm not sure how it improves this because their immune system is down, right? So will it help? Yeah, it's a good question. And also how to boost them, right? Do we have to boost them over time? Yeah. I don't know what you think.
Well, I don't know. I think I'm not sure if the HPV immune response to the vaccine would be that bad in GATA2. So it's a dead vaccine. So I would recommend to vaccinate. And
yeah, absolutely.
Hope,
yeah, we do that too.
Hope for better than not being vaccinated. So I would like to summarize 2 questions here, also for you, Marcin. It's about early diagnosis of GATA2 patients. How would you recommend, what is your main advice, how to optimize prompt diagnosis, especially when patients are being cared for in different specialty clinics? And do you recommend annual bone marrow only starting at school age in asymptomatic patients? What is the earliest reported case of leukemia in GATA2 deficiency?
That's excellent. I think the best diagnosis you reach with GATA2 gene sequencing, and also if you have a phenotype that is consistent with GATA2, I would also look at, and if you don't find a mutation, I would make sure your panel is covering the intron 4 mutations, the hypomorphic mutations, which most panel now do. And also, if you still don't find this and you suspect it, I would do a CGH array to make sure you're not missing a whole gene deletion, right? A large deletion, which we find in few cases already. So that in terms of the diagnosis. And I think the best people to diagnose GATA2 deficiency are immunologists and hematologists, obviously, because these are the most common denominator phenotypes, right? The stem cell deficiency leading to cytopenia and immunodeficiency. And in terms of the second question, in terms of the earliest leukemias we found, so we found one 4-year-old kid with MDS monosomy 7, that was the youngest one. Then the true MDS, you know, the advanced MDS with monosomy 7 high-risk features, they start around age 7, 8, 9. And this is where we would definitely, I think we would not do bone marrows in younger kids, younger than 5 or 6. So our approach would be, if we have a patient with identified GATA2 mutations through family analysis, right? Like the parents had it or siblings, we find a young kid that is, let's say, 1-year-old. We would first do a CBC and immune cell subsets, immunoglobulins. And then we could see the kid once per year, only checking the CBC, the blood counts, and the lymphocyte subsets. And then if there is some change in the blood counts, around school age, 6, 7, this is where we would probably start doing the bone marrows. And then my approach would be to do annual bone marrows just to see how it changes over time. And then again, you could also catch the monosomy 7 potentially, and that would trigger the transplant right away. And now there's some newer approaches where you could do somatic gene analysis or somatic testing through peripheral blood. So for example, we are sending SNP array from peripheral blood or CGH array from peripheral blood to look for monosomy 7. I have to tell you that the sensitivity is lower, but the sensitivity is lower, but the specificity is high. So basically, if you find monosomy 7 in peripheral blood, it's definitely in the bone marrow. If you don't find monosomy 7 in peripheral blood by genomic array, that means you can still have it in the bone marrow. You might have missed it. But I still think, that we might get there over the next few years. We might get there to develop more sensitive methods where we can do the somatic testing from blood, because the lesions like monosomy 7, this is most prevalent in children. So this would trigger the transplant, right?
Thank you, Marcin.
Marcin, can I ask you one question? Very short. do you agree that all patients with AML and monosomy 7 should be screened for GATA2?
Absolutely, yeah. So even if you have a disease that looks like AML, potentially de novo AML, and not like MDS, AML arising from MDS, I would definitely recommend doing the GATA2 screening, because in a subset of these AML, de novo AML cases, you might have GATA2 deficiency. Yes, absolutely.
We have another interesting question for you. Do you know anything about susceptibility to mycobacterial infections in patients with somatic GATA2 mutations?
Yeah, very, very good question. So I think I personally have not made that experience, but it was published in few things so far, at least 3 or 4 patients. One study was from MD Anderson and another study from another center, where essentially a patient who developed GATA2 somatic mutation at the stage of myeloid malignancy had also an associated severe immunodeficiency that looked like GATA2 deficiency. So it was basically an acquired GATA2 deficiency phenotype, which is quite striking. And then, of course, these patients have increased risk for mycobacterial infections, right? It's rare, but it's possible, right? So if and this happened so far only in adults.
I have another question myself after what you said before. So what we are doing is molecular pathology for a panel in peripheral blood on somatic mutations, like in ASXL1 and all the risk genes. And we actually find some lately, for example, also in a patient with a RUNX1 familial platelet disorder, which prompted us to go into transplant right away. So how do you value this additional information of peripheral blood NGS testing for somatic mutations? Does this replace bone marrow, one or the other bone marrow analysis?
Yeah, I think this is really, really great question. And I think we are now at the time, exciting time actually, for, where genomics is really helping us in our clinical care. And I think that, and I want to show you just one thing, where we actually did an analysis of, it's actually, give me a second, I want to open that. I want to show you something interesting. So basically, sorry, give me a second. So we did a small study where we compared bone marrow to peripheral blood somatic testing. And in this study, I just need to open it, sorry. I cannot open it. So somehow I cannot open it, but anyway, so we see a very good correlation between bone marrow and peripheral blood in terms of detecting of somatic mutations. Because, if you have a panel that has sensitivity down to 1%, you will be able to identify the mutations, usually in the peripheral blood as well. So for the majority of cases, there were only maybe 2 or 3 cases where we were not able to identify the somatic mutation in peripheral blood, but it was found in the bone marrow. But in the bone marrow, it was below 1%. It was very low, like clinically insignificant probably. But all the other somatic mutations we were able to detect in peripheral blood. So you could argue that that we will be doing at one point, maybe instead of bone marrow, if it's not needed, we might do somatic testing in peripheral blood. For now, at least we could boost our surveillance strategy by, for example, in high-risk conditions like GATA2, recommending somatic mutation testing in between, in intervals, once a year bone marrow, and then every 6 months, like in between, you can do somatic testing from blood. So this is our approach now, that after 6 months, and if a patient, let's say a 10-year-old with GATA2 deficiency, with cytopenia, obviously we cannot do bone marrow every couple of months, so we would do bone marrow once a year. And then after 6 months, we do somatic testing, meaning a myeloid mutation gene panel, like to check for A601 and ZBP1, and also SNP array to check for monosomy 7.
Okay, yeah, thank you, Martin. So are there any? I don't see any more questions except for one.
can I show this? Sorry, if I still have, gonna take only 1 minute. So here what we did was, we looked at the cohort of 80 children with bone marrow failure, and some of them had GATA2. And we look at the concordance of paired NGS test peripheral blood bone marrow. So here you see the correlation in panel E, variant allelic frequency in bone marrow and peripheral blood. So it's quite good. There is no difference in panel B. There is no difference in allelic frequencies in the median between bone marrow peripheral blood. And also in the germline variants, which is on C, there is no difference. And what is actually interesting in this figure F, you see that there are some clones that can be higher in peripheral blood actually, which we did not expect. And there are some clones which are higher in bone marrow. So for higher in bone marrow, for example, somatic SAM-D9L mutations, those are the ones in red on the right side. Then P53, PCOR, ZBP1, A601, PIK-A. And on the left, some clones which are higher in peripheral blood. So again, some SAM-D9Ls. So because they might actually revert the lymphocytes, they might arise in lymphocytes. So maybe that's why they enrich in peripheral blood. And then we see CSF3R mutations, which are enriched in peripheral blood as opposed to marrow, maybe because they provide a boost for differentiation, so they differentiate better these cells. That's why we see them a little bit more in peripheral blood. So what I'm trying to say is that there is a good correlation between bone marrow and peripheral blood compartments. And I think we should advocate for using peripheral blood as a standard source.
Yeah, thank you very much, Martin. This was really nice to see also the last figure that you showed us. If there are no further questions, I would really like to thank all the speakers and also Delphine, even if she was not here today, for preparing part of the data. And I would like to thank all the panelists and for the discussion. Would anybody like to say anything before I close with the closing slides? And please don't leave before I show the closing slides, because we have more news to show. Okay, so I don't see anything. Please interrupt me if I missed something. Then I would like to ask for the final slides, please. Thank you. So with this, I would like to advertise a journal, because it's not one of the huge commercial publishing houses, but actually Rockefeller University Press, together with the International Association of Primary Immunodeficiency Societies like ESID, for example, co-owning the Journal of Human Immunity, which will launch its first issue very, very soon. Please look at the website, Journal of Human Immunity, within the next few days. And I think there is exciting literature, exciting educational material, exciting new scientific findings to be found in this new journal. Then I would like to advertise a meeting on more or less the same topics that we discussed today, organized together from ESID with the European Hematology Association and the Society for Pediatric Oncology Europe, which will take place in November, 18 to 20 of November this year in Vienna. Beautiful city. I really like Vienna, and you will like it if you join us. The meaning of this focused symposium is really to connect people from different disciplines and enhance the discussion and exchange knowledge there. So please join us in Vienna. And yeah, with this, I would like every participant for joining us today. ESID has a lot of activities, not only educational, but much of it is dedicated to education, to awareness, to training. There are lots of junior activities, really fun, summer schools, winter schools. If you're not yet a member, please consider joining. The membership fee is not very high, and it saves you, I think it saves you even more on the conference fee than the membership costs. So actually, it's really a good deal. I have been working on an honorary basis for ESID for, yeah, I think it's almost 20 years or so. And I learned a lot and I had a lot of fun with it. So it would be good to join. And with this, thanks everybody. I don't know if somebody else would like to have a final word.
Just thank you.
Yeah, thanks Michael for co-organizing. Thanks every speaker for taking the time. Yeah.
Thank you very much. Thank you all.
Thank you.
Good night.
Bye.
Ciao. Ciao,
Thank
everyone.
you. Bye.
Bye.